Go ahead.
So, good evening, everyone, and thank you very much, sir, for this opportunity. So, today, what we are going to discuss is one of the most important articles, or sort of a revolutionizing article, on the pre-myopia. So, this was the article shared, and I'll be taking you through the merits and demerits of what has been happening these days. So, as we all know, that myopia is a global health challenge, and the most quoted study for all the myopia work done till date is that by 2050, 50% of the population is going to turn myopic. Now, traditionally, just a spectacle prescription was given for myopes. From that, the focus shifted to slowing down the progression, but still it was not enough looking at the amount of increasing myopia worldwide. So, what was happening till date is that retarding the progression, either in terms of how it started with progressive lenses and then different sorts of myopia control spectacles going to the high and low concentration atropine, different types of uh, soft contact lenses and GP lenses, and the orthokeratology were given. Along with that, the environmental modifications were also studied to be the most effective ones. So, if you see in the Chinese school, there were the modifications done in terms of the working distance maintenance, and also not very clear in the picture, but a lot of sunlight. So the roofs were kept such that the sunlight is penetrating much, and long hours in the sunlight was preferred rather than being in the room. So, yet along with the environmental modification plus this myopia control strategies were not found to be very effective, because it was only retarding the progression, it was not working on the prevention part. So this is the study which actually talks about the prevention of the myopia. So if we detect a pre-myopia at an early stage, we would be probably able to talk about it. So, the objective of the study was to develop and validate a prediction model that would identify the children who are likely to develop myopia within 1 year, and these models could propose a new clinical definition for pre-myopia supporting the early intervention. So key points to discuss, or the aim for us to discuss this study, is that the focus is shifting from myopia progression to myopia prevention. Traditional definitions of pre-myopia were using only static refraction, which is not enough, because we have studied in the previous sessions that biometry is utmost important. The risk-based approach for early intervention is to be discussed, and the clinical definitions are needed for the pre-myopia, because still the e-metropization process and the understanding awareness is much lower. So there was a need of the definition needed. So what they did was they selected. Sir, can I continue? So in their study, they selected three longitudinal cohorts. The first one was the from Gonzalo twin study, the
So,
outdoor activity
so
study.
just a minute,
Yes.
Devanshi, just a minute. So the previous slide, as she has rightly pointed out, the point is that now we have shifted from the traditional definitions of pre-myopia to the fact that what are the pointers which will stop them or prevent from myopia progression itself. So that was the key objective. And to be honest, this particular study which we have selected, this particular study is the baseline for, if you see, she will show the tables and we will discuss it at that point also. These are the tables on which bulk of the myopia calculators or risk scoring system or pre-myopia scoring system are based. The reason why I want to point it out right now is so that everybody should be alert when Devanshi shows the tables. Please continue, Devanshi. You are not audible, Devanshi.
Is it okay now?
Yes, yes.
Okay,
Please,
okay,
please.
sorry. So there were the three longitudinal cohorts selected. So basically, the myopia data set was selected from these three studies, out of which two were from Guangzhou. So this were being used as the internal ones, and then one which was selected as the Scrum study from the Singapore, which was used for the external validation. Now, from this data set, the children aged between 6 to 16 years and those who were non-myopic at the baseline were followed up for 1 year, and the data was taken. So basically, two, six, seven, eight non-myopic children with the age range of 6 to 16 years, out of which 252 from GTS, 652 from goals, and 177 from the Scrum study were taken. So for their methodology, they included the predictors to be number one, the cycloplegic refraction and considering the spherical equivalent value. The second one was the axial length. Next, they considered the biometry in terms of anterior chamber depth, uncorrected visual acuity, age, sex, corneal curvature radius, and parental myopia. So, what they did is they designed, sorry, so they designed a logistic regression model. So there were three models which they designed. So based on the predictors, so I'm going back to the slide to show the predictors again. We know that biometry is important. We know that spherical equivalent refractive values are important. Now, based on this, they tried to bifurcate it into the three different models. The first model, which was considering the first model was considering the refraction values, so cycloplegic spherical equivalent. The second model was focusing on the biometry values, and the third one was a simplified biometry where it was the axial length to the corneal radius ratio was to be considered. So now creating these three models, there were probably three different goals as well. The first one could be used into the clinics where we have an option to do a cycloplegia. The second one, where ocular biometry was considered, but cycloplegia was not considered, so it could be used as a community screening or a school screening device. And the third one, where uh, cycloplegia was not involved and just an ALCR ratio was much focused along with the uncorrected visual acuity. So it could have been used as a quick screening for the fewer matrices. So now, based on the data sets they have chosen, they created these three models and underwent the validation process. So what they found is commonly in between all the three models, what was found is that younger the age is directly proportional to higher chances of myopia. More myopic parents, again, it is directly proportional. Worse the uncorrected visual acuity at the first go, again, there is chances to develop myopia within a year. Longer the axial length or higher the AL to CR ratio or less hyperopia at the baseline. So these were the key predictors across all the three models. And from these three models, they were able to comment upon the pre-myopia cutoff threshold. So I'll come back to this slide once we discuss each individual tables over here. So the first one, what they did was that they had selected three different parameters, and for each of the parameter they had commented upon what would be the risk score. So this is the study which is as used as the first study which is giving the integer based risk score. So for the first model, they used the cycloplegic spherical equivalent, that means the dioptric power values, along with the age, number of myopic parents, and whether the patient is male or female, and then they assign the points based on the categories. So for the first model, which was based on the cycloplegic spherical equivalent, they assigned the points into category wise based on the diopter. So when at the first go, if the power of the dioptric power is between 0.25 to 0.01, then the assigned point was given. So based on that, the spherical equivalent were considered, but along with that, the myopic parents were also taken care into. The second model, which was the ocular biometry based, where each of the parameter for biometry was considered, but in this case, the dioptric power was not considered. So, talking about the axial length, the corneal curvature radius, anterior chamber depth, uncorrected visual acuity, age, number of myopic parents, and again, uh, the sex of the patient. So, when if the axial length was around 22.5 mm, the assigned point was 0. So basically, this ocular biometry based risk system is considering more of the emetropization stage rather than the dioptric powers. So likewise, with the increasing in the axial length, higher the points were assigned. So the next model, which is the comparison between ALCR ratio based risk score. So of course, the most important factor was here the ALCR ratio. Along with that, anterior chamber depth, uncorrected visual acuity, age, number of myopic parents. So when we talk about ALCR ratio, if it was between 2.9 to 3, a point was assigned to be +2. If it was more than 3, a higher risk, that means a +4 was given. So basically, I'm going back to the previous slides just to make a comparison note that for each of the model, the way they designed the model, for each of this model, a particular scoring system was developed, and this scoring system uh, was considered along with comparison between myopic parents. If there is no myopic, I mean, neither of the parent are myopic, there was score given as 0. If both parents are myopic, the score given was the higher score. So talking about a common factor from all three of them, so it was found to be a around 70% of risk associated with myopia within next 1 year, which was found. So when they created this integer based system, so based on the prediction models, three studies were taken. The two were from Guangzhou. So a prediction model was first based on that. Then an external evaluation based on the Singapore study was done, and then the comparison for the predictions were found out. So now looking at this integer based system, the question would arise, or the discussion points are, should the clinical interventions begin at the pre-myopia stage? If the risk score is, let's say, a 6, or if the risk score is 5, we know that this is a higher risk patient, then should we begin with the interventions? Can this model be used for a school screening program, or how to use it as a digital app, and when to ethically label someone as a pre-myope? So from this study, we found the clinical relevance that children with low hyperopia or early emetropia, along with those who have parents who are myopic, are at higher risk and should be monitored closely. The risk-based definition of premyopia allows the targeted early interventions. So early interventions can be started initially with the lifestyle changes and later could be shifted to the other modalities for myopia control. Now, what was the novel contribution? So the first validated integer risk score system was given from this study. It was giving a short-term prediction because it was for a 1 year prediction and gives a stricter myopia cutoffs. So the strength of the study, number one, it was a multi-centric and multi-ethnic cohorts. They developed a clinically applicable risk score. The external validation was also done, so which was adding the reliability we saw in the earlier graphs. And the cycloplagia refraction based model was given, which was excellent predictive power. But there were certain limitations, including a smaller sample size in certain subgroups. Next, it was mostly the East Asian data taken, so ethnic diversity. It was just a 12-month follow-up, so a short-term follow-up that it could make more sense when a long-term follow-up could be assessed. And the risk model was not validated in case of low myopic incidence. These were all the non-myopic children considered.
Yeah.
So they,
Can we?
yes, sir.
Yeah, yeah. Go ahead. Go ahead. No, no, go ahead. Go ahead.
They concluded that cycloplegic refraction is the best single predictor of myopia onset. They offered the practical tools for early identification and intervention in children at risk of myopia, and also they gave a specific definition which was age based, and pre-myopia cutoff was given. So basically, the study provides the evidence based and age adjusted risk stratified criteria which could be used as a guideline before deciding the interventions for the patients. Thank you.
Can we move on to the previous slides, like the
Yes, sir.
third last slide, the third last slide? Yeah, this one. No, no, the second next. No, no, no. You've gone too far. Next and next and next. Yeah. So maybe I can answer some of the questions, and then we can back and forth take the questions. And if there are any other questions, we can take. So now the first point is whether we should intervene at the pre-myopia stage. We did some work on this, and this was a very small subset of patients. They were actually, we had around 65, 70 odd patients. All these patients in which we intervened, there were 30 patients in which we intervened, and there were around so there were more number of patients in which we could not intervene, despite knowing that they would progress and despite telling them that you would progress. So there were only 30-35 patients who agreed, and at that point of time, this was like way back in 2020. So by back then we did not really had access to glasses, but so these were patients in whom either there was a little bit of family history, not of high myopia, but parents were very much aware that the child was losing his glass power very quickly. Uh, so as to say that the child was losing his hyperopic reserve very quickly, and because it was happening, they knew. So the point which we have to take from that is there are 2 points. One is that we should do axial length of almost all the patients in which we think, according to the scoring system, or even as clinicians, as as people who are practicing myopia, if we feel that this particular patient could be a pre-myope, say he has a plus 0.25 with a cylinder of 1, or he had 1 and then he became zero point 0.5, and we measured axial length at zero point 0.5, not at 1. So if you start measuring axial length of children who are hypermetropic, then you would end up measuring axial length like you are measuring visual acuity of all patients. So you should be aware that this particular patient may be a high risk patient, or at least the patient is at risk. And as Devanshi said, and congratulations to her for a wonderful presentation. Pre-myopia is a risk profile. So you have to understand that this particular patient may actually be having pre-myopia, and so you start gathering the data for that particular patient. Once you have the data that the axial length is actually increasing with the same machine at different times, you can definitely start clinical interventions even when the patient is emetropic. But you have rock solid data that this particular patient is actually was having an axial length of 22.9, and now his axial length is 23.1, and so you know that this patient is definitely going to progress. And that is where your counseling, when patient was seen at a pre-myopia stage, was done to the patient that he's losing out his plus very quickly. There's a chance that he may develop myopia. I'm not starting anything, and I may start the drug after I see the patient again after 6 months or 4 months. Now, can we use these models in school screening again? uh, Very aptly told by Devanshi, we have to generate the fact that premyopia is a risk profile. So you can use this model in school screening program and say, or label these particular kids as premyopic. You are not starting any treatment, but these are pre-myopic. You may start a treatment if you feel that these pre-myopes are losing the hyperopic reserve quickly, or are going towards myopia very quickly. How can this model be integrated into digital tools for broader access? Well, they are already, that they are already available by, there are at least two apps which are there. And day before yesterday, I was talking with one of the you know optical biometer people, and they are planning to integrate these pre-myopia scoring system or risk scoring grading systems, like Myopia Master has got it integrated because of BHVI. So they are being integrated with optical biometers, but we don't really truly need an optical biometer with integration, because we can ourselves go and download it and see it. But if you have access to such a machine, it is much better. But use the this particular model or this particular risk scoring system, because these all models, these all even when you do an OCT or something like that, they are all for the patients. All these red, blue, green, all these color coding systems are for patients, for us to make sure that they understand what we are saying. So these risk scoring systems are wonderful to bring the point home, to tell the patient that this, your kid is at a risk and he may develop myopia at a later date, and this is the risk based system which is saying that there is a risk. We are not starting treatment, or we are not putting intervention based on a risk scoring system. We are just being sure that you follow it up after 6 months, and if there is an actual progression, see, without progression it is extremely difficult. Whenever you are treating myopia, just try to remember your glaucoma practice. Without an actual progression, just based on one number,
Very good.
you cannot treat. Hello.
Patching समझाओ તમે.
Yeah. So what are the ethical implications of labeling a child with premyopia? We are just trying to say that this particular patient may develop myopia, and because this patient may develop myopia, the most important thing is that patient has to be followed up closely, so that if the patient develops myopia, we are there to intervene. Or if the patient is very close to pre-myopia, still has been to minus 0.25, we can still intervene and make sure that the myopia progression slows down or does not progress at all. So this was regarding this, and we can now discuss all the uh, all the thing which we had in the lecture, or we can discuss whatever was there in this particular article, because this particular article is one of those articles which started all this about scoring system. Previous to this article, there was not much of scoring system, especially for pre-myopia. So if there are any questions, we can take. Devanshi, if you have a question.
Sir, I had a question while preparing this. As a practice, like how we are teaching students the subjective refraction and cycloplegic refraction. So conventionally, there is a tonus allowance which is to be deducted. So whatever values here or in the any articles which we are referring, everything is a net retinoscopy as per the deducted tonus allowance, or it is not a usual practice.
Uh, Honestly speaking, all these articles will have values which are actually uh, dilated refraction with an autoref. They are not truly retinoscopy readings with a deduction of tonus. So normally what they do is, normally in all these studies from China, they have a cycloplegic refraction on the autoref. And they normally in their methodology, they clearly mention that they did a cycloplegia and the pupil size was measured. There was a baseline, and there was a protocol that it should be big. The pupil should be bigger than this, and a drop was put, and a time was set that if you have put the drops 3 times for 40 minutes, after 40 minutes there were 5 readings which were taken. And in case that there was a difference of reading, again they took some readings and then they averaged out. So normally they don't they will not do a refraction and a subjective correction, because they don't want any subjectivity. See, when in a study you don't want a pure subjectivity. In our clinic, normally we would do a study, and we would try to put more of what patient is reading. So normally, sometimes if you have a cycloplegic refraction, your prescription may be 0.25 diopters more, or maybe 0.5 diopters less than the cycloplegic refraction. It depends, as you said, it depends on the subjectivity.
Okay, sir, thank you. Sir, I just wanted to add one more point. Probably as a strength, we could have, I could have included one more point here is normally we don't have an habit of sending those parents for a genetic counseling for myopia, but this could even be used for counseling the parents, even if like it is a zero spherical equivalent value for the child as of now, but both parents are myopic, so this could be even used into that aspect as well.
Yes, you can do that. I mean, but the problem is that just so so genetics in myopia is something. So there are two three subgroups in what we talk about genetics. So the basic subgroup, one of the important subgroups, as you said, is that the parents are myope and the kid is myope. So there's the autosomal dominant. There's a direct gene transfer from parents to the kid. So there are certain genes which can be expressed only if you are indoors. So the gene is such that it makes you susceptible to myopia, but it doesn't make you myopic. I don't know whether that makes sense or not. What I'm trying to say is that once you become myope, the gene will make you susceptible for progression, but it will not make you susceptible towards myopia. If the environmental factors do not make you a myope, your myopia will not progress. So that is another subset. So so genetic, so whatever you get from parents is the genotype, and when the gene gets expressed, that is the phenotype.
Okay, sir,
I don't know
understood.
whether it made sense or not,
No,
but
I had gone through the Green study and the
yes.
upregulated and the downregulated genes. So I think I would again go back and read that. Thank you, sir.
Hello.
Hello.
Yes,
Yeah, sir, I had a question. Hello, can you hear me?
yes, please go ahead,
Yeah,
Minas.
sir, coming to the implication of the study, there are two things that I want to ask. One is opportunistic screening, as in, if a child comes into the clinic, walks in for some other problem, and maybe a trivial trauma or something like that, and does not have any of the other risk factors, especially parental myopia or sibling myopia. Does that child also, and he's 6'6" without any stenotic symptoms, does that child also warrant cycloplegic refraction with home atropine or cyclopentolate? And second thing is the data sufficiently strong enough to warrant cycloplegic refraction in communities?
Uh, so first, see, if the child doesn't have any complaint, it would be very difficult to convince the patient that we want to do a cycloplegic refraction. So what I personally do in such patients is that I will take a baseline axial length and a baseline keratometry and a baseline autoref, not a cycloplegic refraction. Now the kid is reading 6'6". Parents don't want to talk about it because they really feel that the kid is reading 6'6". He doesn't have a problem, but still you have a baseline data, and this particular baseline data is objective. This is not subjective data. See,
Okay.
cycloplegic refraction is a very important indicator of whether you will have myopia or not. But at the end of the day, even if you do a cycloplegic refraction, there is always some subjectivity to it. See, your refraction and my refraction will not 100% match, although we may prescribe the same glass. So what I'm trying to say is that axial length and keratometry, at least you do it, you put it in the file, and you just write it that you did it for some purpose. Now you know that when this patient is going to come back, you are going to repeat the same thing, and you are going to tell the patient that if he becomes a myope or if he progresses, you can always tell the patient that, see, I had done this 6 months back, and I have again done this, and he will progress. Now this patient now knows that you have done some workup, and this patient you have already told, you have already done a quite a thing that you have already told them that he is going to progress. And if he progresses after 4 months, then that patient will never question you why you are giving atropine, because now he knows that you already knew it.
Okay.
It is always evidence based, which helps. I mean, there are a lot of today only I saw a patient showed somewhere in Australia and had just come to discuss the case. Now patient has there are a lot of take home messages from that. Patient came to me. Patient has a glass par of -1 with -2.5 cylinder in both eyes. So this patient has been told that you need a DIMS glass, because that will reduce the progression. So patient came to me. He said that should we go for the glass? His sister, this is his sister's daughter, and this patient has come to me in India. I told him, see, the glass is for progression. There is no documented progression. So always go for the evidence. Never prescribe it, because patient will always take a second opinion when you talk about such things which are still in infancy, because only 30% of the people in the country still practice myopia. So if you give atropine and if you tell the patient that with this his glass power may not increase, he will immediately go and take a second opinion. Let him go. That's a good thing. The point is that you should have evidence which backs you when you tell him that his glass has progressed, and only then you are giving. You're not giving it empirically. There is no empirical prescription or giving glasses empirically. You are giving because you had the reading, you had axial length, and nobody can deny axial length when the axial length is actually progressing and it is correlating with his glass power. There is no, it's all in white and black. So the second question was whether what was the in the community, what was this? I
Yeah,
don't
so
remember.
whether does it warrant, do these studies warrant tell us that now probably psychopathic refraction should be included in community screening, or that is still too far-fetched? Uh,
Uh, See, honestly speaking, whenever I did or whenever we went to do school screening, even in trust hospitals or in private practice, the model we follow is that we will go to the school, we'll check the vision. If vision is 6669, we will not say anything to the kid. But if the patient is reading less than 69, he is reading 612, we tell the patient you have to come to the hospital and we'll do cycloplegic refraction. That is the baseline. We don't mess around without cycloplegic refraction in children less than 18 years. There is no point. It is it is extremely, you may get away with it with 80-85% of children, but still you will miss out very easily. They accommodate so much that it is extremely difficult to find out whether they are accommodating or not accommodating without cycloplegic refraction.
I have a
okay.
My point is that if you are going to give glasses to the patient, you should always do cycloplegic refraction.
Yeah, definitely. That is.
Yes. Sir, can you hear me?
Yes.
Yeah.
This is,
Yeah, hi,
yeah.
sir. So my question is like regarding the pre-myopia definition, like the cutoff values which have been defined, it's on a very broader range. Like if we see it's like plus 0.75 for children less than 6 years. And again, it's like 0 or minus 0.25 above 10 to 11 years. So
Yes.
how to apply this particular broader range in a clinical practice?
But that is bound to happen, doctor, because the problem is that pre-myopia, I think one of the good take-home, it's just to tell you that there is a risk profile which is attached to this particular refraction at this particular age. The wonderful part of the whole thing is in the fact that it is trying to take the whole age group. So if you take an age group from 6 to 14 years, you have to give a cutoff refraction from plus 0.75 to minus 0.75, because a child with 15 years of age, we know that his
Yes.
axial length is not his axial length is not going to grow much. Can you
True.
switch off, Dr. Shweta, can you switch off your mic, please? Yeah, thank you. So my point being that if you are taking a very large age group, every particular age group is susceptible at a certain level, and then it ceases to be susceptible. So if you have a refraction of +1 at 12 years of age, you are no more a premyope. How can you be a premyope? You have only 3 or 4 years, and it is definitive that at 12 years of age, uh, a +1 is not going to lose his hyperopia so quickly that he becomes a significant myope. So I think that is where the whole beauty of definition is, that they are trying to encompass on a very larger group. At the same time, they are trying to essentially enforce the fact that each age has a different normative data. So for each age, they are saying that at this age, this is fine. At 14 years of age, if you are plus 0.5, there's hardly any risk. You're more or less past the age where you can develop myopia.
So I also had a question for the evaluation part.
Yes.
When do you do the corneal topography? Like, why do you suggest it? Is it usually I do a topography, sir, for significant astigmatism is there or a high myopic patient is there. So, what is like your take on doing a corneal topography for a routine myopic patient or in specific conditions only?
Normally, we don't do topography in routine patients, but bulk of the because I do lot of work based on research. I don't want to miss out on a patient who has who has a slight paracentral steepness, and we miss out on that because normally keratometry would take only central to 2.5 millimeters. So I'm not saying that for a normal practice we should do a topo for all the patients. And in our list of investigations, we always say that at least keratometry, axial length, AL upon CR ratio, cycloplegic refraction would normally suffice. Having said that, as you have already said, that if there is an astigmatism, if there is a slight steepening even in the paracentral level, there will be some changes in the central 2 to 3 millimeter, and keratometry would show some changes, but not always. So only because we try to go towards research, and we try to find out that we should not be missing out on odd cases. That is the reason. So sometimes you can have an indication that sometimes if your axial length growth is not much and the power is still increasing and keratometry is also stable, you can go for a topography just to see what is if you are missing out on certain paracentral areas where some ectasia is there or some steepness is there. But apart from that, no, topography is not really a routine. You don't need to do it in all the patients.
Thank you, sir.
Excuse me, sir. Yeah, I have a question.
Yes, yes,
So,
doctor.
how frequently should we do the axial length checkup for the patients? And like as you said, when if even if the axial length doesn't change and the refractive power changes, so should we consider myopia control strategy?
So, so these are few things which are still in gray area. So number one is how frequently we should do axial length. So if the glass power is in, say if the normally we would do it at 6 months. So that is the normal protocol. Now if the patient comes to you at 3 months and his glass power has increased, so in your own way, you want to find out whether this is axial progression or whether this is accommodation which patient is doing or whether this is corneal progression. Because if there is a progression, you have to find out why it is. So that brings us to your second question, that if axial length has not progressed, what has changed? So in my own practice, I have seen patients where sometimes axial length has not changed, and sometimes if you do a stronger cyclopledge, you would see that the change is not much. And sometimes axial length has actually progressed, and the glass power has not changed. Patient is still accepting the same power. These patients, the second set of patients, these patients will come back after 2 or 2.5 months, and they will have progression in refraction also. I don't know why this happens. Uh, Currently, we don't have any working hypothesis as to why this happens, but it has happened in almost 6 to 7 patients where I could see that axial length has progressed, especially with DIMS and with these stylus lenses. Axial length progresses first, and then after 2 3 months patient comes and he has a dip in vision, and then he has a increase of zero point 0.5 or 0.75. So nowadays if axial length changes and the glass power has not changed, I sort of predict and I sort of tell the patient that his axial length has increased. I think he would need higher power. Right now the patient is using and reading 6.6 with the glass, but we will not follow up after 6 months. We will see this particular patient after 3 months. So, and if we go to the first set of patients where axial length has not changed and power has increased, maybe this also will be a set of patient where there is something in the axial length, the sensitivity of the machine. And if you do a repeat axial length, it should show some change, or cornea should show some change. Because at the end of the day, there has to be something.
Okay, sir. Sir, one more thing also, this axial length and CR ratio, should we consider that more or only this thing we can consider?
It is just another way of saying the same thing. If you see axial length versus CR ratio is similar to what axial length is saying. The fact of the matter is there's a good article by Dr. Sandra where she says, or there's another article which they followed from Arvind Eye Hospital. Dr. Urvashi, if you can mute the phone. Uh, yeah. So axial length upon CR ratio explains in their conclusion. If you read that article which was published in IGO 2 months back, what they say is that axial length upon CR ratio explains the variance of the whole progression much more easily, mainly because you are dividing the axial length their with their corneal radius. Now what is I will try to go little bit, I will try to explain. See, basically the power of the eye is defined by corneal power and axial length. Now you have corneal power right there, and you are defining it with the axial length, or defining it with the radius, the curvature radius. Now, if you divide your axial length with the curvature radius, what you are essentially trying to do is you are trying to break it out that this is the axial length, this is the focal length of a particular optical apparatus, and this is the focal length. I mean, the corneal radius is basically the power. So, if you are dividing the axial length with the power, you are trying to find a ratio which can be more sensitive. If you look at axial length and if you look at the corneal reading, it will tell you the same thing. So there is nothing in axial length upon CR ratio. It is just that it summarizes it more quickly for the patient. And you can say that, okay, the cutoff is 3, or the cutoff is 2.9 for your patients, or the cutoff is 3.4. Similarly, as they have this scoring system, these scoring systems are not absolute. The scoring systems are there. And another article says that a scoring system of a score of 4 is good for UK patients. We have to do our own study in India to find out which is the optimal score for Indian patients, whether it is 3 or 4 or 5. So it varies in your practice. All these things are for your advantage to tell the patient. As a clinician, honestly speaking, it will just tell you that these particular patients warrant more attention. If they don't progress, despite having a axial length upon CR ratio of 4 or a risk score of 6, if they are not progressing, we are not going to start the treatment. So the point is, this is only for making sure that we know that this particular patient is at a risk. Like you are taking intraocular pressure for the patient, a pressure of 24 with a CD ratio of 0.2. He is just an ocular hypertensive. We are not going to start any treatment. This is only to know that, okay, his pressures remain high, and then you look for thick corneas. So all these things are only for your knowledge and to transparent it to the patient. Your treatment is not based on scoring systems. Your treatment is not based on axial length upon CR ratio. Your treatment is based on the fact that this particular patient is progressing, and only then you are starting the treatment. All this is a risk factor grading system so that you know that this patient has to be watched out more carefully, and also to tell the patient that, see, this is your scoring system, there is more likelihood that you will progress in coming days. Does that make sense? I mean,
Yes, yes, sir.
I don't
Thank
know.
you, thank you,
Yeah,
sir.
yeah,
Yeah, yeah, I
yeah.
understood, sir. Yeah, thank you. And one more thing, how do we explain the patient, even if with the myopia control glasses and or combination therapy, if it still increases, how do we explain them?
Okay, I'll go back to the second lecture. See, never take that guilt on you that it is increasing because of you. Never do that. You are not a person who has been given divine power to treat the patient. You are doing your best to tell the patient that these are the options available, and that's it. You have to tell the patient that, if he keeps on working in for near for more than 3 hours or 4 hours, I cannot do anything. I'm just trying to help you out here. Environmental modifications are the key, and they have to follow the environmental modifications. Nobody can fight with genetics and environmental modification. What you are trying to do is you have to tell the patient that, think of the condition. If I would not have introduced glasses and atropine, his power would have been even more. So never take that blame on you that, if it is increasing, it is your fault. Not at all. Even if
Uh,
otherwise also, if you have done a good surgery and patient has some issue, you just see that you have done the good job. It is not your fault. You can find out whether it is your fault or not, and once you are convinced it is not your fault, don't blame yourself.
so
Sir,
should
good
we
evening, sir.
give that BHVI calculator, that chart for the patients to explain the risk, like without and
You
with
should
the
always,
treatment?
if patient is not getting convinced, you have to take out printouts and give it to the patient that this is your risk factor, this is your scoring grade, and you may increase. This you have to do it when the patient comes first to you, not at the second visit, at the first visit. And next, when he progresses, you can be the holy grail that, oh, I have predicted, see, you have increased. So you have to do it in the first visit.
Sir,
Oh,
can we
okay, sir.
take
Yeah,
it
thank you.
into, can we convert the graph or chart from the PHPI calculator into the PDF format, sir?
You can take a screenshot and take a print.
Okay, sir. Sir, another doubt, in cases of compound hypermetropic astigmatism, when the child is around 10 or 11-year-old with plus 1.5 with minus 2.5 cylinder, how would we progress, sir?
These patients normally would not go towards myopia. At the age of 10 years, if he has a hyperopic reserve of 1.5, very difficult that this patient would go for myopia progression.
So irrespective of the cylindrical power, we will only be considering the spherical power set here.
Dr. Saab, we have to understand here that the cylindrical power is coming from the cornea. His cornea
Cornea.
has something. We just leave it there. We see axial length and corneal power as two separate points, and then try to understand that so if the cornea is steep, suppose if the cornea is 46, his axial length is bound to be small. See, that is the wonderful part. If you see a Dahan's article, or if you see couple of other articles, you will see that how nature completely changes everything. The cornea will be steep. In my case, I will tell you my own case. My axial length is 27 and my K is 40. And I was a myope of 2.5 when I was 10 in 10th standard. And by 12th standard, I was minus 3.25. And by the time I was in college, I progressed after 18 years of age. Now, axial length went to 27.6 and my K reading was completely flat. So this is a very classic example of AL upon CR ratio that you can see for yourself that body was trying to compensate by keeping cornea flat, because body knew that his axial length, there is a, even if nobody knew, I didn't know, body knew that his axial length is going to increase, he is on the higher side, cornea became flat. So that is the balance that eye is trying to maintain. A patient whose axial length, if you are talking about plus 1.5 astigmatism with a minus 2 cylinder, this plus 1.5, his axial length will be on the shorter side. With that axial length and at the age of 10 years, the patient will not go towards myopia. But you have, in this patient also, you can take axial length, you can take AL upon CR ratio, keep it in the file. When the patient comes to you after 6 months, if he is losing his hyperopia quickly, you can just point it out to the patient, see, he's losing his hyperopia quickly. And at 10 years, you want him to lose his hyperopia quickly. Only when he loses it to 0.5, if he is 10, 1.5, 11, 1, 12.5, and 13, if he becomes 0 or 0.25, now you can tell patient, see, I have already measured your this thing. Strange, but this particular child is doing something. We don't know what he's doing. He must be reading a lot, or he must be a lot into near work, but he's losing his hypermetropia more quickly at 10 years of age, and he is at a risk of developing myopia. Most of the parents, they will see that you have done a workup, they will see the whole curve graph, and they would easily understand that yes, their kid will become myopic.
Okay, sir. Thank you.
Sir, I have a question.
Yes, ma'am.
Sir, when we take parental myopia as one of the risk factors, does the degree of myopia in them also play a role? Like if the parents
uh,
have, one of the
yes, yes,
parent
i
has a
got
point
i got it
five.
i got it No, no,
Yes,
I will tell you,
yes.
there are 5 6 studies on this. They're very very good studies, you should read them. One of the
Yes.
studies says that if the parents are high myope, there's a chance that kid will develop myopia very quickly, whereas other study
Okay.
says that even if parents have astigmatism, kids can have myopic. Another study says that the degree of myopia which parents have does not define the myopia of the kid, even if they are low myopes. So basically, what I would say is that there is not enough data to pinpoint what is going on. Number one.
What's
Number two, there may be some genes which are not expressed completely in parents, and suddenly, because of the environmental factors, got expressed completely in kids. So at this point of time, I don't think there is enough data to absolutely say that if parents are high myope, kids are bound to be high myope.
okay?
But
Okay,
yes, if parents are myope, that is a risk factor, and that is where uh, they have just stopped. They have not gone into depth of how much myope parents are and whether that affects or not. They have not gone into the depth neither in the calculators nor in the discussions that normally happen. But yes, out of curiosity, I did read these articles because this is pretty interesting whether we can make a model of predictability based on parents' myopia. But it
yes.
completely fails when it comes to low myop parents having children with very early myopia.
Yes, sir. I had this doubt because of the same issue. The mother has only a point 0.5 sphere, minus 0.5 sphere, whereas the kid is 5, 6 years old, and she has around minus 6 diopters now, sir. So that
It
was
is
the
very
reason for my
variable.
doubt. Yes,
Honestly, it is very, very variable. There is
thank you, sir.
no direct correlation or evidence that this particular myopia correlates with that. There is no
Yes, sir.
direct evidence.
Okay, sir. Thank you, sir.
Sir, another doubt, sir. In premyopia, for example, a child is around 8, 9 year old with who is accepting plus 0.75 spherical. So for those, if for example we have done all the evaluation and we have got a score and we felt that he needs anti-myopia therapy. So here, for example, if we want to go to the DIMS lens, uh, should we go with the normal spherical power, whichever he is accepting with the DIMS, or what, sir? Or
I think DIMS or Stillest. Last I was talking with their uh, this guy, the research person. I think they have got Plano. They have got Plano. This thing. Plano Stillest or Plano DIMS. I don't know if they have DIMS with plus power or not.
yes, or not? Okay, sir. Okay.
But they definitely, so I will share it in the group. They
That's right.
recently, Halt Lenses came up with a study where they have given glasses uh, to non-myopic children, which are peripheral defocus lenses to non-myopic children. It just came today, so I have not read it whether it had plus power or not. But I think it is with this thing, Plano glass with peripheral defocus.
Okay, sir. Okay.
That they have
Then
a
we have
no plus power.
They have with plus power.
No, no, they don't have a plus power. Comes only minus lens.
Yeah,
Minus power only.
I thought so. I don't think
Mhm.
they have it. I thought probably for research. So we are doing a joint work. Dr. Madhvi, if we can switch off the mic. Uh, नहीं 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 हो रहा है यहाँ से नहीं हो रहा कंट्रोल यहाँ से भी नहीं हो रहा so I think they recently I had a we are doing some work for SLR people. They are having Plano with this, but let me read that article because I did not read it. He sent it to me today only, but I didn't read it. I can forward it in the group, but I don't think that they have with plus lenses. You are right.
So one more doubt. So should we give power for the kids who are accepting 0.75, 0.5 like that, plus 0.5?
So in my practice, I just see their vision, and if there are no asthenopic symptoms, there is no esotropia, everything binocular workup is done, and everything is normal. I don't prescribe till plus one also. So I mean, I don't prescribe if there is no need for that. But if you yeah, so this article, so that is what we do in our practice right now. So if there is a, so I think I had read an article where I think our colleagues in Southern Hemisphere, Australia, they give bifocals to children who are less than 8 years with these plus lenses. They feel that because kids will not accept plus 1.5 when they're very young, their accommodation is very strong, so they do give progressive or plus bifocals, saying that if you give these by, I think I read couple of articles where they said that if you give these glasses, the learning disabilities are less. We never found that happening in India, so we really don't prescribe plus lenses.
Sir, we have a lot
Sir,
of children coming between the ages of 12 to 15 who are treatment naive, but who have documented progression. So, is there any upper age limit where we stop advocating myopia progression treatment?
No, no, no. There is no upper age limit. Honestly, there's no upper. I don't follow any age limit. And I have a wonderful anecdote for this, that why there should not be an upper age limit and why there are so many people who have upper age limit. The reason for bulk of this thing is that bulk of the articles and bulk of the atom 1, atom 2, lamp 1, 2, 3, 4, all of them were done between 5 to 15 years of age, because these were research works, these were not clinical works. They have a certain protocol, they have to go through institutional ethical committee, they have to go through review boards. So they have to define age as an age where progression is maximum, and they are doing something which is making a difference. But in normal practice, I would do myopia control till 20 years of age also if there is a progression.
Okay. And sir, recently I had a couple of patients who were diagnosed as myopia elsewhere
Yes.
as a first diagnosis, and were
Okay.
prescribed atropine. So, without having any documented progression, do we stop atropine in such patients and tell them that we can wait for progression and restart it again?
Yeah, so there are three things which you can tell the patient, because the risk why these three things you have to do is because if you stop atropine and if the patient progresses, the previous doctor will immediately say, see, he will become more of a, he will be like more prophecy kind of thing, that you see, I told you that it will progress, and it is your doctor who told you to stop the drops. So what you have to tell the patient is that, like I did with this particular patient, I told him, number one, you are using drops for what? For stopping the progression. There is no progression in your kid. Number two, if there is no progression, it is very difficult to know whether it is not because of atropine or even otherwise. And then there is third thing, that almost 30 to 35% of the patients do not progress. So not all the patients progress. Yes, a bulk of around 65 to 70% do progress, but almost 30% don't progress. So it is there. It is there in the literature. Even you yourself will see that there are a lot of patients out of there's a good number of subset of patients who do not progress. Regardless, they will come to you for years and they will be like that only. So I think you can uh, tell the patient
Talk to the
facts.
patient, and then
Yes, and tell that, atropine, although there are not a lot of side effects of atropine, but still, why give it when there is, I mean, there is no progression. You have to document the progression to give the drops. It is like giving timolol eye drops.
right,
Patient comes to you, you have 22 pressure, you gave timolol, and then somebody else saw the patient and he stopped timolol, and nobody knows what is going
right,
on, because
right.
because there is no progression.
So it's always better to have a documented
Very
proof
true.
of
Very true.
progression.
Very, very true. At least for our purpose, we should always have documentation, because if patient comes back to us saying, why did you
Right,
start at present, we should have a backup.
correct. Thank you.
sir,
And
how
doctor,
was
one very important thing is, even if the child progresses, you can tell the parent, even if the child progresses, he's not going to progress from 1 to 2.5. He's going to progress from 1 to 1.5, maximum 1.5 in a year. and you are going to see the patient after 4 months or 6 months. If the patient is so scared, he's going to come back to you very quickly. So you are going to see
Right.
him anyway in 6 months. इतना progress
Correct.
नहीं होने वाला है कि it is
Yeah. Right.
going
Right.
beyond the reach.
Right. Right.
Yes,
Sir,
Dr. Sir.
how much increase in axial length is considered significant, sir?
0.2 to
Um,
0.0.
okay, okay, sir.
Yes.
Thank you.
So in type 1 premyopes who have high risk factors, do you prefer low dose atropine BD or a combination therapy?
I I prefer them BD. I tell them to start BD in the beginning itself.
Okay.
And in fact, some of the patients, I tell them that you have a option of combination therapy. I'm starting BD, and there's a chance that even with BD, the kid is not going to respond. So we may start we may so normally we would start combination therapy when we have waited enough to prove that atropine is not working and the patient is a non-responder. With type 1 patients, we know that there's a very good chance that patient would be a non-responder.
Yes, sir.
So what if we first identify a child as a pre-myope at around 6 years of age, and we start the child on low-dose atropine? How long do we give that? For 2 years?
See, I will tell you one thing. This 2 years, I mean, this is between, this is not off the record, but honestly speaking, this 2 year thing started. Why did it start? And I
With a
think I will
study.
again, yeah, I will again be telling this when I will be talking about atropine in the next talk. The study was there for 2 years. So the safety profile has been studied for 2 years. Now, not everything will have to be studied in the studies. We do use the drug. So we did a study. We presented it in AIUS, and we had done this study for 3 years, not for 2 years, because we were not doing atropine 1%. Atom 1 was atropine 1%, and justifiably, it was there for 2 years. In fact, in 2 years itself, there was almost an anisometropia of 0.77 diopters between the two eyes. So they had randomized the eyes, not the patients, whereas we had
Yes.
randomized the patients. So we were not at a risk of developing an isometropia, and we used it for 3 years, and that was for 0.01%. So I think you can safely use it even if you are starting very early. Next thing is you can always increase the dose and you can continue it for 3 years. We have done work
Okay,
for
so
3 years.
continue for 3 years, and then what do we do? Then we taper and see, look
Then
for
we taper and
progression.
see if yes, if the patient is having a rebound or not. Higher the drops, higher the rebound, and
So
better
I'm
the
talking about pre-myopia alone. I'm talking only about pre-myopia. So what do we do after 3 years? We taper and stop,
no,
and
no.
then look if the
Pre-myope
child
you
goes in.
can no pre-myope you can stop after 2 years itself just to see.
Okay, sir.
I thought it was a general question.
No, sir.
So
No, sir.
pre-myope you can stop after 2 years just to see, just to see and tell the patient that this has been 2 years. We tried it out for 2 years. The progression is minimal. We can taper it and see what is the result. And if the need is there, we may restart it.
Okay.
And sometimes parents would just tell you that they don't want to stop. They don't want to taper it because the power has not increased. So they don't want to do it. And then you can continue it for more time.
I was only worried about the number of years. If we start early, like if I start around 6 years or 7 years, so how long do
No,
we
no,
continue?
you can safely continue. So even Atom 2, the follow-up study which was published, they used the drop for 2 years, stopped for some time, and then again restarted.
Then
So they had a
restarted. Yes.
5 year, yeah, they had almost a 5 year follow-up.
Okay, sir. Thank you, sir.
Sir, when we use it, BD, should we record the pupil size or anything, sir, or for the
Yes,
low
yes,
dose
always.
atropine?
No, always. You should always record the pupil size. Pupil size, you should record if you are giving atropine because, you should always be on the safer side when it comes to using atropine. Even if it is not off label, it is a published thing, but you should always try to record pupil size so that whether before the patient tells you, you can tell the patient that pupil size is more, and that is the reason we are reducing or tapering or not going to higher concentration, because you should have more information than the patient. Why not record the pupil size? It is much easier. Nowadays, even autorefs have that, pupil recording softwares. The newer autorefs can record pupil size.
Sir, can you little more light on, like, do we need to stop or taper the drop?
I didn't get the question. I'm sorry.
Sir, the pupil size you told that if it is more, we have to taper. So can you throw a little more light regarding like
No,
how
not that,
much
not that.
at what?
No. I didn't mean that if the pupil size is large, you have to stop atropine. What I meant was that if patient tells you that the child is photophobic, you should have the data. You can immediately tell the patient that yes, pupil size is more, and that is why he is photophobic. Not that if patient is not complaining and patient is adapting well, there is no need to stop. But if you have pupil size, you can easily tell the patient, yes, his pupil is so it is, and a patient obviously sees that you have on paper, you have the pupil size before you started atropine, and he sees that you have pupil size on the visit, so he knows that you are measuring it.
Okay, sir.
Sir,
Thank you.
can we handle the same cases, continue atropine and give them photochromatic lenses or something like that?
We can do that, but normally क्या होता है, patient themselves don't want to, once they have this problem of photophobia, there are very few patients who have that, but if they have that, the jest in which they want, control of glasses, that sort of goes away. If they are very much photophobic, it doesn't, the photochromatic glasses will not make a huge difference. I have some patients who said that if there is photochromatic glasses, it is fine. I told them, yes, I don't mind. I mean, as long as it is purely a subjective complaint. So if they are photophobic and they can do away with photochromatic glasses, good, very good for them. I mean, we can do, definitely we can do. Normally they just refuse that, the kid refuses that he will not put the drop. They immediately come back after a week and they tell that the kid is not able to bear the side effects of atropine.
Sir, what percent of your cases may be needing twice a day atropine eye drops, sir?
Uh, with time, I have become greedy. So, whatever control they have, I want better control. So, lot of patients, once they come back after 6 months or 8 months, and their progression is very minimal, but I can see that there is still some progression. I would tell them, why don't you put twice a day? So, a lot of patients. I have, in fact, like Dr. Reena asked, some of the pre-myopes I start twice a day directly itself.
Okay, sir. Okay.
Somehow I feel that in Indian population, it is a good idea to start with twice a day, because near work is huge. They don't listen, and twice a day, a lot of patients who are progressing very quickly, I will start directly with twice a day.
Sir,
So,
now some companies are coming with a 0.05%.
Yes,
So would you prefer
yes, always.
0.01% twice a day or
Point.
0.05% once a day?
So I will tell you, Dr. Sabha, we have finished our work on 0.05. Last year we presented at AIOS. 0.05 is definitely better than 0.0501. Uh, 0.0, 0.05 is much better than 0.01 twice a day. It has much more stronger, stronger control. But the problem is that when you are going to taper it, it has got a stronger rebound. That is definitely there.
Okay,
So I
sir.
would always
Thanks.
prefer 0.05. In fact, I think once 0.05 comes in the market, bulk of us, all of us, would start using 0.05. And only if 0.05 is causing photophobia, we will go back to 0.01. Otherwise, why will we use 0.01 when we know that 0.05 is going to give a more stronger control?
Point
Yes, sir.
zero 0.05 with BD dose is also, you are giving that also, sir?
No, no,
0.05 with
no.
BD dose?
So there are three patients, or I think four patients in which we have given 0.05 BD dose, but all of them, all of them are post cataract patients. They are pediatric cataract patients who are progressing. They have a very large myopic shift. They are very quickly going towards myopia. So in those patients, I have started 0.05 because there is no risk of loss of accommodation. So, uh, are there any other questions, or we can? See, we can, if you have any questions, still we can still have a discussion in the group also. If we have questions, we can take, or else we can just put it in the group. And next time when we have a Zoom meeting, we can take that. Not like that. Okay. Okay. No, I don't think anybody has a question. No. Fine. So we will just close the meeting. Is there any other questions? Okay.
No, sir.
So I will.
Thank you.
So the next
No,
topic
sir.
would be
Thank you, sir.
on
Thank you, sir.
atropine and atropine control of myopia, and then we will have a Zoom meeting for the same.
Sir, just a request, sir, if you can put a good articles on peripheral refraction measurement and its role.
I will be doing that. I will be doing that, and I will send you a device also, and I will put videos also how to
Okay.
use that. That will be after atropine. Just because we are going with this thing, and not that we can't do it. I cannot. I can put some articles, but I would be taking peripheral refraction as a separate subject, because peripheral refraction, optical control of myopia is basically based on peripheral refraction. So we will have to talk and understand why peripheral refraction is important, and what in peripheral refraction is important, how much peripheral is important.
Yes, sir. Great, sir. Thank you.
Thank you. Thank you.
Thank you, sir.
Anything? Okay.
Thank you, sir.
Okay. Good night.
Thank you, sir.
Good
Thank
night,
you.
sir.
Good night.